Good
Please
evening.
wait for Chief. Okay, yes, it's recording now. Thank you.
Good evening,
Please, you can
colleagues.
start.
Okay, good evening, senior colleagues and colleagues. I'm Dr. Florence Briggs. I'll be taking us today on congenital cyanotic heart disease. Sorry, there. I'm trying to change my slides. Okay. So this is the format I'm going to follow. And yeah, so starting introducing what cyanosis is. Cyanosis basically just results from when there's an abnormal communication, when we have a right to left shunt, which leads to poor oxygenation of blood, meaning that on the right side of the heart, we have poorly oxygenated blood, or the blood in the right of the heart is poorly oxygenated, or it is deoxygenated. So when there's shunting of blood from the right side of the heart down into the left side of the heart, there's now mixture of both the deoxygenated blood and oxygenated blood, thereby reducing the concentration of oxygenated blood being distributed into systemic circulation. So that brings about what poor oxygenation to the body, and then they present with cyanosis. Cyanotic heart disease. Cyanotic heart disease is a defect or group of defects in the structure or the function of the heart or the great vessel. So it may not just be the heart that is affected. It may be the vessels alone that are affected. And then it is termed cyanotic heart disease, provided the patient presents with cyanosis. So patients present with cyanosis at birth, and then it's said to be consistent with abnormal blood flow, as I said, from the right side of the heart, which is deoxygenated, to the left part of the heart, that's circulating blood from the right to the left side of the heart, thereby reducing the oxygenation of blood getting to the systemic circulation. So this is said to occur at the level of the atria, the ventricles, or the great vessels. So now, adaptive mechanism, what actually happens when a patient is cyanosed? So basically what happens is that there's what we call stimulation of erythropoietin. When there's cyanosis, the body just picks it as, okay, there's reduced hemoglobin. You know, hemoglobin is that which carries oxygen. So what happens is that erythropoietin is stimulated to produce secondary erythrocytosis, meaning that we have more of red blood cells being produced. And indirectly, this does what increases the outputs of this patient. So basically, when a patient is cyanosis, what happens is that we have what we call a compensatory secondary erythrocytosis to try to increase the cardiac output in this patient. So this brings about what hyperviscosity syndrome in this patient. So that's basically what happens when a patient presents with cyanosis. So now we have different classifications of cyanotic heart disease. We have the one based on ductal independent mixing lesion. We also have the one of ductal dependent pulmonary flow. And also we have the one of lesion with ductal dependent systemic blood flow. So for ductal independent mixing, this basically results from when there's pulmonary and systemic mixing. This then leads towards deoxygenation of the arterial blood. So this has got to do with what mixture of the pulmonary and the systemic blood, and that brings about the deoxygenation of arterial blood that gets into the systemic circulation, while that of the duct-dependent pulmonary blood flow, that one actually is dependent on the shunting, where we have left to right shunt from the aorta to the pulmonary arteries through the ducts. So this particular one actually goes through the shunts. Like we actually have in tricuspid atresia, in the tetralogy of Fallot, we actually have maybe a VSD or an ASD. So there's actually a shunt. There's actually a right to left shunt. So this is actually how this portrays its own mechanism of action to bring about cyanosis in these patients with congenital heart disease. Then that of the lesion with ductal dependent systemic blood flow, that basically is dependent on the patent ductus. That's when there's, by right at birth, there's supposed to be a disconnection between the pulmonary artery and the aorta. But because it is patent, what happens is that there's now what's mixture of blood. There's now what we call mixture of blood from the pulmonary artery, which is deoxygenated, and then it gets into the aorta. And then there's now what's reduced oxygen concentration of blood getting into the systemic circulation. So this is how these set of people with the hypoplastic left heart syndrome, interrupted aortic arc, and also total anomalous pulmonary venous connection with obstruction actually work. So they are dependent on the patent ductus, that's ductus arteriosus, while the ductal dependent pulmonary blood flow are those that are dependent on the shunts. Then that of the ductal independent mixing lesion, they just have a way of, there's a mechanism of which results from the pulmonary and systemic circulation mixing together and then bringing about deoxygenation into the systemic circulation. Then we also have other classifications from increased pulmonary blood flow, decreased pulmonary blood flow, and then obstruction to systemic blood flow. So for those of them that are classed under the increased pulmonary blood flow are what we call the total anomalous pulmonary venous return. You know, for total anomalous venous return, what actually happens is that by right, the pulmonary vein is supposed to drain into the left atrium, but in this case, everything drains into the right atrium. So there's increased pulmonary blood flow into the pulmonary circulation in this case, as well as truncus arteriosus. As we go down, I'll discuss more about that. Then for the decreased pulmonary blood flow, we all know that in tetralogy of Fallot, we have a component called pulmonary stenosis. So because there's a stenosed valve at the pulmonary level, there's reduced pulmonary blood flow to the lungs. So that's what brings about the decreased pulmonary blood flow. The same thing occurs with transposition of great arteries, tricuspid atresia, because in tricuspid atresia, there's total occlusion of the tricuspid valve. So blood doesn't get into the right ventricle and then gets into the pulmonary circulation. So this is the classification of drugs placed under decreased pulmonary blood flow. Then we have for obstruction, systemic blood flow. So basically in hypoplastic left heart syndrome, the left heart is actually hypoplastic due to either the mitral or the aortic valve is being atretic or it's being stenosed. So because it's poorly supplied with blood, become hypoplastic, is not functional. Therefore, there's reduced blood supply into the systemic circulation because the aortic valve is atretic or it is stenosed. So this is what we place under obstructive obstruction systemic circulation when we have the hypoplastic left heart syndrome. So yes, so this is a risk reduction strategies like what are patients supposed to avoid when there's a background cyanotic heart disease. So when you have a patient who is pregnant, you try to avoid pregnancy in patients with Menger syndrome and also in cyanotic patients with pulmonary artery hypertension or patients who have arterial oxygen saturation less than 90. Pregnancies please be avoided in such patients. Then also iron deficiency anemia should also, these are prophylactic measures to the mainstay of care to avoid complications. We try to avoid iron deficiency anemia in such patients because it can actually precipitate or worsen the outcome of this patient. And when also we have inappropriate anticoagulation, you know, there's the backflow of blood, there's mixture of blood from the shunting of blood, which can result in a paradoxical embolus. And also when there's an inappropriate anticoagulation, this patient may be at risk of the stroke. So we should be very careful of inappropriate anticoagulation with a patient with a background cyanotic heart disease. Dehydration. Try to avoid dehydration in such patients because dehydration can actually predispose to hyperviscosity in this patient. Infections. When the patient is infected with any of these respiratory tract infections, please, we should try to make sure we give them influenza vaccines and also pneumococcal vaccines to prevent infective endocarditis because patients with this disease are at risk of having infective endocarditis. So we prevent such patients from doing what's smoking, cigarette smoking. We stop them from excessive alcohol intake. And then also we avoid strenuous activities for them and then prevent exposure to heat. Then also, even if they have to be on contraception, they should avoid estrogen-containing contraception because estrogen-containing contraception actually causes fluid retention and it also predisposes them to thromboembolic events. And also, we should try to make sure, even if the patient has to be on contraception, they should avoid taking the one containing estrogen contraceptives. Then also, if the patients, we should try to make sure they use air filters to prevent air embolism, as well as other things that are listed here. I don't waste much of your time. So natural history of cyanotic heart disease. Mortality is significantly higher in the cyanotic patients as compared to the acyanotic patients. Why? Because these patients are actually short of oxygen. The body needs oxygen. So patients with cyanotic heart disease will come down with more mortalities as compared to acyanotic heart disease. Then the outcome is determined by the underlying anatomy, the pathophysiology, complications of cyanosis, and also the preventive measures taken in such casualties. Then we can actually predict premature deaths in this patient. In predicting premature deaths in this patient, we realize that patients who has low platelet counts, severe hypoxemia, cardiomegaly, and also elevated hematocrit are actually predictors to poor prognosis. So patients with these parameters are actually classed under the poor prognostic class. Then iron deficiency has been said to be associated with an adverse late outcome. BMP also has been predicted, it's a predictive outcome for Semenga's patient due to the outstretch of the ventricles and all. So we've had multi-centered studies that have said that only age, pre-tricuspid shunt, absence of sinus rhythm, and all have been said to be a strong predictor for death in these patients. So progressive hypoxemia in the first year of life is expected. Survival to adult life is actually rare without palliation. So most of these patients who come down with cyanotic heart disease, a corrective measure should please be done. Otherwise, mortality is high over time. Then the presence of additional source of blood supply actually modifies the rates of progression of cyanosis and its complications in this patient. So how do they present? Will be cyanotic, either from the shunt, right to left shunt, either from obstruction to the aortic outflow tract, that's the left ventricular outflow tract, or either from reduced blood flow to the pulmonary vasculature. All of these can predispose this patient to cyanosis. As usual, they'll be dyspneic, failure to thrive, because each step they take, they become very dyspneic, they become very weak, so they won't be able to thrive as the usual people do. Then squatting positions after physical activities actually relieve their breathlessness. It has been said that squatting positions actually increase the peripheral vascular resistance, thereby reducing the right to left shunt in this patient. So when the right to left shunt in this patient is reduced, what happens is that cyanosis is actually reduced because there's reduced concentration of oxygen. When right to left shunt is reduced, what happens is that oxygenation is better being distributed into systemic circulation. Then also they present with what hypoxemic spells, which is characterized by anxiety, hyperventilation, or sudden increase in cyanosis. They can also present with syncope due to risk cardiac output, chest pain, arrhythmias, and then heart failure. So now I'll go one after the other with the different cyanotic heart diseases. So we have the tetralogy of Fallot. As we all know, it has four features. We have the non-restrictive VSD, that's ventricular septal defect. We also have a widening of the aorta, pulmonary stenosis, right ventricular hypertrophy. So tetralogy of Fallot has been divided into syndromic and non-syndromic patients. For the syndromic patient, 20% of them are actually syndromic, where we have the chromosomal effect, the trisomy 21 and others, and the non-syndromic patients, where we have majority of them. So the standard mortality rates amongst these patients are actually with repaired TOF, meaning that if you're comparing a patient who has actually had a repair from TOF as compared to somebody who has a simple defect as ASD or VSD, the people who have actually had a repair from TOF are actually twice, they have more mortality, twice more than a patient who actually comes down with a simple defect. meaning that a simple defect is actually way better as compared to those who have had repairs from TUF. So natural history. So basically, following a transannular patch repair, what happens is that we have a significant amount of people coming down with pulmonary regurgitation. And most times when we have a severe coronary pulmonary regurgitation, what happens is that it eventually leads to symptomatic right ventricular dilatation and right ventricular dysfunction in these patients. So now what happens is that we actually have poor outcomes. Poor outcomes are actually determined from elevated right ventricular pressure and also from right ventricular hypertrophy. So these are actually the poor outcomes patient with tetralogy of Fallot. Then residual ventricular defects actually occur from failure of complete closure time of surgery. So when the closure is not completely done, what happens is that they present with a residual VSD. Aortic complications can also occur over time following surgical repair. Then we have the right and the left ventricular dysfunction or heart failure. So for the right ventricular dilatation, this usually is due to residual long-standing pulmonary regurgitation and or obstruction to the right ventricular outflow tract, while the left ventricular dilatation has been attributed to long-standing palliative arterial shunts, residual VSDs, and also aortic regurgitation. So both of them can actually occur. We can actually have both right ventricular and left ventricular dysfunction, and this has been said to be attributed to long-standing cyanosis before repair and or inadequate myocardial protection during repair. So patients can also present with arrhythmia, sudden cardiac death, and also endocarditis. So for the pathophysiology, so basically the degree of cyanosis actually reflects the severity of the right ventricular outflow tract obstruction. So basically in tetralogy of Fallot, it's the level of or the degree of obstruction at the right ventricular outflow tract that determines the level of cyanosis in this patient, meaning that if the patient actually has a mild pulmonary stenosis, most times they are asymptomatic, but from moderate to severe, most times the patients come down with what cyanosis because there's reduced blood flow to the pulmonary vasculature. So that worsens the cyanosis. So that is the hallmark of the TUF. The degree of obstruction at the right ventricular outflow tract is determinant of the severity of cyanosis in these patients. So some of them can actually present with tetralogy spells, which all of a sudden you notice fall in the arterial oxygen saturation due to obstruction still at the pulmonary level, and this is said to be life-threatening in them. So these are associated anomalies in TUF. They can have right aortic arc, of which we have 25% of them who can present with that. Anterior descending artery origins from the right coronary arteries, origin of the left main stem rotating clockwise, also absent pulmonary valve syndrome. Then we also have the dilated aneurysmal pulmonary artery. So these are congenital abnormalities that can occur with tetralogy of Fallot. So this basically is just showing us a picture of a patient with tetralogy of Fallot. So the first component is right ventricle. This is the right ventricle. So you notice that there's hypertrophy of the right ventricle in this patient. And then there's a VSD. So if you notice, there's an opening, there's a bridge in the ventricular septum. Then also there's an overriding of the aorta. So the aorta is supposed to be attached to the left ventricle, but at this point in time, it's attached at the ventricular septum, interventricular septum. So this is the overriding of the aorta, and this is obstruction of the right ventricular outflow tract. So basically, this is just showing us a picture of a patient with tetralogy of Fallot. So now diagnostic workup of these patients. Sorry, I'm trying to look this up. So basically, what happens is that this patient presents with a wide split in the second heart sound. Why? Because there's actually a delay in the closure of the pulmonary valve due to stenosis. So it causes a wide split second heart sound in these patients. Then they can also present with a low pitch early end diastolic murmur that is suggestive of what severe pulmonary regurgitation. They can also present with systolic murmurs from pulmonary stenosis as well. Then ECG often shows a complete right bundle branch block depending on the surgical approach of these patients. So looking at the workup of these patients, when the patient does a chest radiograph, it actually presents with a boot-shaped heart. And what happens is that this is not really showing, the next picture I'm going to describe it better. So in a boot-shaped heart, what happens is that the right ventricle is actually bulging out because of the right hypertrophy that you see in TUF. So you notice a bulging of the right ventricle. And then also the arc most times is tilted towards the right in the patient with tetralogy of Fallot. So this is what it looks like, the boot-shaped heart. You know, the right ventricle is hypertrophied. So normally the left ventricle is usually a little more prominent as compared to the right ventricle. But here you notice that the right ventricle is also enlarged, due to right ventricular hypertrophy in this patient. And then if you look at the arc is tilting more to the right as compared to it being on the left. So this is what you see of a chest radiograph with someone with tetralogy of Fallot. Okay, so this picture basically is an echocardiographic picture showing us a patient with tetralogy of Fallot. This is parasternal short axis. So yeah, if you notice here, the arrow is actually pointing at the pulmonary valve. The pulmonary valve looks thickened, and looking at it, it looks stenosed. So that's basically what this picture is showing us, a stenosed pulmonary valve. And here, the second picture is showing us the parasternal long axis of the patient, where you notice a bridge in the ventricular septum, where this shows us the VSD in this patient. And if you, so this is what basically this picture is showing us, the VSD in this patient, and here it's showing us the pulmonary stenosis in this patient with TF. Then here, the echocardiography is actually showing us the level of right ventricular outflow tract.
Getting something successful, like you be wealthy. Babies are a new life, they are new beginning. If you get any of the video, just know that the road will be open.
I didn't get it. What did you say? Sorry.
Sorry, I've muted the person. You can continue.
Okay. Sorry. Okay, so basically, this picture is the parasternal short axis under color Doppler, showing us that the patient actually has a pulmonary regurgitation. You know, I said that they can actually coexist with pulmonary regurgitation as well as pulmonary stenosis. So this picture is the parasternal short axis of a patient with COF showing pulmonary regurgitation. If you notice, you can see the mosaic pattern. And then if you go down here, looking at the max PG, the max PG is about 2. The max PG is about 2. So the stenosis is actually mild in this patient. When it's less than 3, it is mild. So it's actually mild in here. And then patient also has a pulmonary regurgitation. So that's basically what this picture is showing us in a patient with TUF. So this is a picture of a cardiac magnetic resonance imaging. So this is actually showing us the image of the right ventricular outflow tract. You notice that there's some form of aneurysm in here, because I think that's like a compensation. Most times you see right ventricular outflow tract aneurysm coexisting with the pulmonary stenosis. So that's basically what this is showing us. And this is also trying to assess the right ventricular volume in this patient. So the cardiac MRI in this patient is actually showing us, assessing the right ventricular volume, and also showing us the size, the shape, and also the expansion of the pulmonary artery. Then the late gadolinium enhancement will actually demonstrate fibrosis, of which this can actually predispose the patient to ventricular tachycardia and then sudden cardiac death. So now, other things that can be done, we can do a CT coronary angiography. This would actually help us to give us the information of the coronary arteries to try to know the spatial relationship with the right ventricular outflow tract in a patient who is about to do the pericatheter pulmonary valve implantation. So before you do a pericatheter pulmonary valve implantation, you have to know the spatial relationship of the coronary arteries with the right ventricular outflow tract to prevent some damages from occurring. So basically, the CT coronary angiography would actually tell us the relationship of the coronary arteries with the right ventricular outflow tract before the procedure is being done. Then also there's a room for PET positron emission transmission. This is said to assist the timing of the intervention and then provide prognostic information in this patient. Then there's also a room for Holter monitoring. So this actually just gives us the events, tells us patients who are at risk of inducible sustained VT, and then those who have that prognostic value of clinical VT and sudden cardiac death. So it gives us a picture of people who are at risk, high-risk patients to arrhythmias before this procedure is being carried out. Then the cardiac catheterization basically will just tell us it's actually used when the non-invasive method is not does not suffice. So basically, it gives us a better picture to know the states of the patient, to rule out the stenotic, look at the stenotic level of the patient, look at measure the pressure in the right ventricular outflow tract, and also in the right ventricle as well before the transpulmonary valve implantation is being done in this patient. It can also tell us the spatial relationship too with the right ventricular outflow tract prior to the implantation being done. Okay, so here this is the ESC guidelines for what and what to be done on a patient. Either we are actually doing the pulmonary valve repair, or we are actually doing others for them. So before we actually do a pulmonary valve repair for this patient, the patient has to meet some certain criteria. So if a patient is symptomatic with severe pulmonary regurgitation and or has least moderate right ventricular outflow tract obstruction, meaning that the patient has severe pulmonary regurgitation with moderate to severe right ventricular outflow tract obstruction or moderate to severe pulmonary stenosis, that patient should please have a pulmonary valve replacement done. Then also in a patient with no native outflow tracts, that's those atretic ones, that patient should have a catheter intervention, meaning that the patient should have a transcatheter pulmonary valve implantation done. A patient who has no native outflow tracts being present. Then also, a pulmonary valve repair should be considered in asymptomatic patients with severe pulmonary regurgitation and or pulmonary stenosis when one of these flow criteria is present. So meaning that if a patient has pulmonary regurgitation and pulmonary stenosis or has both of them, there has to be an additional symptom which is listed here. We call them the 2A class. So if this patient actually comes down with decrease in objective exercise and capacity, that patient would meet the criteria for a pulmonary valve repair in addition to severe pulmonary regurgitation and stenosis. Then also, if the patient has a progressive right ventricular dilatation, here we have the right ventricular end systolic volume index greater than 80, or the right ventricular end diastolic volume index greater than 160, and or progression of tricuspid regurgitation, at least moderate. That patient meets the criteria for pulmonary valve repair. Or the patient has a progressive right ventricular systolic dysfunction. Maybe the TAPSE is less than 1.7 with severe pulmonary regurgitation and then pulmonary stenosis. That patient will please need a pulmonary valve repair. Or if the patient has an elevated right ventricular systolic pressure greater than 80, meaning that this patient has pulmonary hypertension. We all know that the normal is 25 to 35. So this is actually classed under severe pulmonary hypertension, which is greater than 60, meaning that if there's pulmonary valve, severe pulmonary regurgitation with stenosis and severe pulmonary hypertension, that patient will please need a pulmonary valve repair being done. Then for the VSD, a VSD closure should be considered. We're taking it step by step because we have a lot of things occurring in TOF. So a VSD closure should be considered in patients with residual VSD and then significant left ventricular volume overload, meaning that if this patient has had, VSD should be considered if this patient is in failure, you understand? And then the patient is also being primed to do a pulmonary valve surgery. So meaning that a patient who is being primed to do a pulmonary valve surgery, who has a background left ventricular volume overload, should please have a VSD closure done as well as the pulmonary valve surgery that the patient already has been booked for. Then in patients with sustained VT, who are undergoing surgical PV, pulmonary valve repair and all of those people would benefit from pulmonary valve repair. Then for patients who have ICD implantation should be considered in selected TUF patients with multiple risk factors, like risk factors for sudden death, patients who have prolonged NQRS complex of greater than 180, or patients who have extensive right ventricular scarring on cardiac magnetic resonance. Such patients should have an ICD done to prevent a VT or prevent sudden cardiac attack from occurring over time. Then a catheter ablation should be considered in a patient with symptomatic monomorphic sustained VT. So these are things that we should look out for in managing this patient, either the patient to benefit from a PV repair, or the patient to benefit from a PV repair and VSD closure, or the patient will benefit from ICD. So everything depends on how the patient presents. Then you now know what treatment modality you give to this patient. So in following up this patient, all patients with TUF should have periodic cardiac follow-up in a specialized adult congenital heart disease center, which in most patients should be done annually. And in follow-up, we should look out for complications in this patient. Then a cardiac magnetic resonance imaging should be done at regular intervals, depending on the pathologies that were found in this patient. So the next one I'm talking about is the tricuspid atresia. Tricuspid atresia, basically, most times we mix up atresia with stenosis. Stenosis is partial closure, partial occlusion of the tricuspid valve, but atresia is total occlusion or hypoplastic tricuspid valve, or a genesis of the tricuspid valve. So basically, in this case, what happens is that what happens in tricuspid atresia, what happens is that the right chambers of the heart become hypoplastic. They become hypoplastic because the aortic valve doesn't allow blood to get into the right side of the heart. So due to loss of function of the right side of the heart becomes what? Hypoplastic. So that's basically what happens in a patient with tricuspid atresia. Okay, so sorry, I'm trying to move to the next. Okay, so this is a picture. This is a gross morphology picture of a patient with with tricuspid atresia. If you look closely, the ST is called the tricuspid sulcus. So there's no communication with the right atrium and then the right ventricle. So you then notice that the right ventricle is now hypoplastic because of loss of function, because there's no blood getting in there. So nature has a way of compensating. So most times, patients with tricuspid atresia normally have a shunt. They normally have an arterioseptal shunt, arterioseptal defect, or a ventriculoseptal defect, so that the blood coming from the superior vena cava will get into the right atrium and then get into the left atrium. And then what happens? It then goes into the left ventricle. Blood then goes from the left ventricle down into the right ventricle and then finds its way into the pulmonary artery. And then it goes back again into the left atrium and then into the left ventricle and then gets back into systemic circulation. So there's just a mixture of blood which would affect the oxygenated blood getting into the systemic circulation. So this brings about cyanosis in this patient. So this is just an echographic picture of the patient with tricuspid atresia. Okay, so now for the pathophysiology of tricuspid atresia. So all patients have mixing of atrial blood. I made mention earlier on of the patient coming down with atrial septal defects, because the body has to compensate for blood to go into the systemic circulation. Otherwise, the patient and the baby will not be compatible with the newborn, will not be compatible with life. So there's a mixing of arterial blood, and thus the degree of cyanosis is governed by the amount of blood flow, the pulmonary blood flow, and then the systemic venous saturation. So as I mentioned earlier on, depending on the amount of oxygenated blood that gets into the systemic circulation, that then determines the level of cyanosis patients will present with. So patients with concordant ventricular arterial connection tend to have more cyanosis depending on the size of the VSD. Whereas with the discordant connection, they are usually pinker, and then they tend to develop heart failure. So basically, when there's an unobstructed pulmonary circulation arising directly from the left ventricle, what happens that they are less cyanosed, but they present more with heart failure in this case. So we also have some, as I mentioned earlier on, these patients will then present with a hypoplastic right ventricle due to an atretic tricuspid valve. So yeah, so this is how the blood circulation goes. So from the superior vena cava, blood gets into the right atrium. There's no communication between the right atrium and the right ventricle. So from the right atrium, it then goes into the left atrium. I said there's a defect on the interatrial septum. So it goes into the left atrium. From the left atrium, it then goes into the left ventricle. From the left ventricle, it goes into the right ventricle, and then it goes into the pulmonary artery. From the pulmonary artery, it gets into the lungs, and then when it gets into the lungs, gets in the pulmonary vein, gets back into the left atrium. So there's a mixture of blood, both deoxygenated and oxygenated, and that's what brings about cyanosis in these patients. So that's how the picture looks like. So when you do an ECG for this patient will present with left axis deviation. Left axis deviation because we have the functional, the dormant chamber of the heart is the left. So we have the left axis deviation, and then we have right atrial enlargement. Right atrial enlargement due to there's blood getting into the right atrium against an atretic tricuspid valve. So what happens is that the right atrium tends to enlarge, and then the pressure in the right atrium then gets higher than that of the left ventricle, and then what happens? There's now a right to left shunt. That's an intra-atrial right to left shunt, and then blood is then shunted from the right down into the left. So when you do an ECG, you have a right atrial enlargement. That's what we call the P pulmonale. And then we also have left ventricular hypertrophy because the dormant chamber of the heart is the left ventricle right now. The right ventricle is dormant, is no more active, it's hypoplastic. So we just have the left ventricle doing the work alone. So because the left ventricle is doing the work of the left ventricle and the right ventricle, it becomes hypertrophied. So you have features suggestive of left ventricular hypertrophy on the ECG. And also left atrial enlargement can also be seen depending on the pulmonary flow. If it is high, there can also be left atrial enlargement because it can be a backflow of blood from the pulmonary if the pressure is high, normally from the pulmonary vasculature, it gets into the left atrium. So if the pressure in the pulmonary vasculature is high, what happens is that it increases the pressure in the left atrium, thereby increasing the size of the left atrium. Then for a chest radiograph, the chest radiograph will see a situs solitus or levocardia in this patient. Sorry, please, let me just read. Okay, so sorry for that. So now the chest radiograph is going to show us a picture of pulmonary vascular markings. You see exaggerated pulmonary vascular markings in a patient with heart failure. You understand? And aside that, most times the pressure in the pulmonary vasculature is high. So when you do a chest radiograph, the markings are usually exaggerated in these patients. Then also the main pulmonary trunk is most times inapparent. Then we can also have the right aortic arc existing in like 25% of these patients. So this is like an additional congenital heart disease that can coexist with tricuspid atresia. Okay, so this is just the echocardiographic. I've actually shown you a picture of the echocardiographic picture, and that is it. This is the looking like a univentricular heart, but if you look very well, you realize that there's a hypoplastic right ventricle somewhere here, and then this is the tricuspid sulcus. So now for cardiac catheterization, this has been said to be helpful to actually assess the degree of subacute stenosis in this patient. Then it can also help us to measure the pulmonary artery pressure and also the resistance prior to venopulmonary connection, because these patients will need an intervention. So it can actually help us to measure the pressure in the pulmonary vasculature. So yes, so in managing these patients will benefit from what we call the black lock Tosin Thomas shunt. So basically this has got to do with shunting of blood from the right subclavian artery to the pulmonary artery. It's trying to bypass the right chamber of the heart, because the right chamber of the heart is hypoplastic. So it's bypassing it so that there'll be no mixture of blood, there'll be no shunting to affect, it's trying to relieve the right to left shunt in this patient. So the patient will benefit from a right subclavian artery pulmonary, right subclavian artery to pulmonary artery anastomosis. So basically what happens is that the end procedure that will be done for this patient is what we call the Fontaine procedure. But the Fontaine procedure is actually done when the patient is about 2 years and above. Why? We're actually waiting for the dormant part of the heart to be able to exert pressure to pump blood out into the systemic circulation. So we want the heart to get mature enough so that that dormant ventricle can actually work like that, like a biventricular heart. So that's why most times they buy time by doing the first, second step, then lastly the Fontaine, which is the final step for this patient. Then also a second step can be done in this patient, what we call the Glenn procedure. The Glenn procedure has got to do with anastomosing the superior vena cava with the pulmonary artery. When you anastomose that, what happens? Blood is taken from the superior vena cava, which carries deoxygenated blood, takes it down to the pulmonary artery, then from there into the lungs. From the lungs, it takes it into the pulmonary vein, and then it gets into the left ventricle, which is the dormant ventricle in these patients. So this is a second step that we can do. Then lastly, we now do the Fontaine. The Fontaine has got to do with anastomosing the inferior vena cava with the pulmonary artery. So that's what we call the Fontaine procedure, and that's done from 2 years and above. Some books say it's done at 5 to 15 years of age. So this is basically what we do for this patient. So here it was mentioned that this should be performed, the Fontaine procedure should be performed when there's good ventricular function, which I just mentioned, and then we should rule out that there's no obstruction at the systemic blood flow. And then there should be a minimal AV valve regurgitation. And the candidate has to be, for this corrective procedure, has to have a low pulmonary resistance. And then also the pulmonary artery pressure should be less than 15. So we are trying to rule out pulmonary hypertension in this patient before we do the Fontaine procedure. So this is the picture showing us the Fontaine procedure and the Glenn. So this is the superior vena cava, anastomosing with the pulmonary artery, and this is the Fontaine, the inferior vena cava, anastomosing with the pulmonary artery. So that's what the procedure looks like. Then now we are going over to the next cyanotic heart disease, hypoplastic left heart syndrome. So this is basically characterized by when the left chamber of the heart is underdeveloped, and then it's said to be associated with what arthritic or stenosed aortic valve or mitral valve, just like the picture of the tricuspid atresia. So due to an aortic stenosis or aortic atresia, this can lead to a patient presenting with a hypoplastic left heart syndrome. Why? Because blood is not taken into the heart, either due to an atretic mitral valve or stenosed mitral valve, or an atretic aortic valve or stenosed aortic valve. So this then brings about hypoplastic left heart syndrome. So here, what happens here is that the hypoplastic left heart syndrome most times is characterized by a duct-dependent system, meaning that it tries to make sure that the connection between the pulmonary artery and the aorta is patent, so that this patient can be compatible with life. Here, they say if this patient is left untreated, this disease is almost fatal in an infant patient, because we need the connection, we need the communication, we need the blood to get into the pulmonary vasculature. So infants actually present with a severe acidemic circulatory collapse. So Okay, trying to go to the next picture. Okay, so this is just a picture of a hypoplastic left heart syndrome. So this is the left side of the heart. So basically what happens is that blood gets into the right atrium. Then from the right atrium, it goes through the tricuspid valve into the right ventricle into the pulmonary artery. Pulmonary artery, it then gets into the lungs, and then it gets into the pulmonary vein. From the pulmonary vein, it takes it now into the left side of the heart. So the reason why this patient actually needs a shunt, that needs the ducts patent, is because the patient needs that communication from the right ventricle. You know that the pulmonary artery is actually it's attached to the right ventricle. So he needs that communication with the aorta, meaning that so that blood can get from the pulmonary artery and then get to the aorta and then get into the systemic circulation. So in this case, most times that patent ductus arteriosus is important in this patient to keep this patient compatible with life. So basically, once this patient is giving birth to, most times we give prostaglandin to try to make sure that that duct that is supposed to be occluded at birth will be left patent so that this patient can be compatible with life, so that blood can be taken into the systemic circulation. So this is the communication with the pulmonary artery, with the aortic valve, with the aorta, so that blood can be taken into the systemic circulation. So this is how this patient can actually survive. So for the pathophysiology in this patient, hypoplastic left heart syndrome actually reflects actually different etiologies that it is being attributed to primary myocardial disease. Some say it's being attributed to an isolated dilated cardiomyopathy in the early fetal life. Then much later, the left heart syndrome then occurs. The left heart then becomes hypoplastic. Some also attribute it to valvular stenosis and then valvular atresia that will lead to hypoplastic, left hypoplastic heart syndrome. So it's actually it's multifactorial in origin. There are various things that can cause it. So in diagnosing this patient, most times it's considered in an infant that when there's a sudden onset of circulatory collapse with severe lactic acidosis, you should be thinking of a left hypoplastic heart syndrome in this patient. So ECG, because the right side of the heart is a dormant chamber, so we are going to have a right axis deviation, we're going to have a right atrial and right ventricular enlargement because the left ventricle is dormant. Is not functional rather. So the right ventricle, the right chamber of the heart is what is dormant. So you have the right side of the heart being enlarged. So when you do an ECG, they give you a picture of a right ventricular hypertrophy, right atrial enlargement, and then we also have STT wave abnormalities on the left precordial leads. The chest radiograph basically just shows you a mild cardiac enlargement shortly after birth. Doesn't really do much. When the patient is in heart failure, you can see vascular markings in the patient. So this is actually a gross picture of a patient with a left heart, hypoplastic left heart syndrome. So this is it. This is what it looks like. If you notice, if you look very well, the left ventricle is hypoplastic, is actually small. The ventricular cavity is small. And then if you look very well, the aortic valve is atretic. So in this case, the cause of this hypoplastic left ventricle is from the atretic aortic valve. So because blood is not getting into the left ventricle, it becomes non-functional, and then it becomes hypoplastic. And then what happens is the myocardium is then thinned out, endocardium is thickened out, and all. So that's basically what happens in a patient with a left hypoplastic heart syndrome. So this is the echocardiography picture. So this is showing the same way, showing the hypoplastic left ventricle. That's the cavity is small, and then look at the valve. It's actually aortic. There's no communication with the aortic opening. So this is what it looks like on echocardiography and the gross picture. So in managing this patient, early treatment with prostaglandin is mandatory because we actually need the ducts to be patent for this patient to survive, to be compatible with life. so that blood can be taken from the right side of the heart into the systemic circulation via the patent duct. So here, patients present in shock. A patient who presents in shock will require mechanical ventilation or ionotropic support in this patient. Then also we need to measure to elevate the pulmonary resistance in this patient to reduce systemic resistance. And then this is frequently required in this patient to help to reduce the apneic nature of this patient. And then in intervening in this patient, what are all of these patients benefit from? You know, we mentioned earlier on that the left side of the heart is actually dormant. So what happens is that the Norwood procedure is what is best for this patient. So there's going to be an anastomosis of the pulmonary. The Norwood procedure has got to do with anastomosis of the distal end of the pulmonary artery with that of the aorta, meaning that it allows blood to pass through the right side of the heart and then gets into the pulmonary artery, gets into the lungs, and then into the pulmonary vein. So there's a connection. It connects with the pulmonary artery, the lungs, and the aorta. Then that oxygenated blood is then sent into the systemic circulation, bypassing the left side of the heart. So this Norwood procedure is what is mostly used for a patient with a hypoplastic left heart syndrome. So that's basically what we use for them. And then survival rates has been higher than 85% in recent studies that have been done. Then there's also a room for Glenn procedure, which I've mentioned earlier on, and also Fontaine procedure. So all of these are done much later in life, but at the initial time, the Norwood is what this patient would benefit from, when there's an anastomosis of the pulmonary artery, the lungs, and then it channels it into the heart, bypassing the left heart, so that these patients can get oxygenated blood into the systemic circulation. Now we have the double inlet ventricle, one of the cyanotic heart diseases. So double inlet ventricle actually falls under the umbrella of a univentricular AV connection. So basically what happens here is that the mitral and the tricuspid valve actually empties into just one ventricle. And most times it's the dormant ventricle it empties into. And we know the dormant ventricle is a left ventricle because it's a high pressure ventricle. But in some percent of cases, in few percent of cases, it empties into the right ventricle. So basically what happens is that the right ventricle, if it's not the dormant ventricle, becomes hypoplastic because the mitral and the tricuspid valve is then emptying into the left ventricle. So this now looks like a univentricular heart defect. So now the morphology. So in about 75% of patients, as I mentioned earlier on, the dormant ventricle is a left ventricle that is separated from the right ventricle by the VSD. So 20% of the dormant ventricle is the right ventricle, and the small incomplete ventricle is of the left ventricular apical morphology. So in only 5% of cases, it is truly only one ventricle in the ventricular mass. So what this picture is trying to tell us is that, yes, it may look univentricular, but most times there's a hypoplastic ventricle. You may see, okay, this is left. It looks like the dormant ventricle is left, but if you look very well, you'll see a hypoplastic ventricle. Most times it's the right, or maybe sometimes the left. But it's only in 5% of cases that you realize that only one ventricle is found in this patient. So that is it about this. So for the pathophysiology, the basic circulatory physiology of double inlet ventricle is identical to that of tricuspid atresia, because in tricuspid atresia, it's just the left ventricle that is functional. But here is that the tricuspid valve and the mitral valve is actually emptying into the left ventricle, if that's the dormant ventricle. So there's a common mixing of systemic and pulmonary venous blood which occurs, and then blood is then injected from the left ventricle into the pulmonary artery or the aorta. So there's actually, if it's shunted into the pulmonary artery, there's a discordant connection. But if it is sent into the aorta, that's what we call the concordant connection. So blood passes through the VSD to gain what's egress to the aorta. So basically, there's an associated subaortic stenosis. The integrity of the atrial septum becomes what's very, very important in this patient. So basically what happens here is that there's a mixture, blood actually gets, deoxygenated blood gets into the right atrium, and from the right atrium, it gets into the dormant ventricle. So the deoxygenated blood then gets into the dormant ventricle. Then that blood, some of them are sent into the pulmonary vasculature, and then it's sent back into the left atrium, and then it gets back into the ventricle. So there's a mixture of blood in this univentricle, and this mixed blood then reduces the concentration of oxygenated blood sent into the systemic circulation. So that brings about what cyanosis in these patients. So clinical features in this patient. So there's a critical reduction of systemic outflow. Infants may be duct dependent and then present with acidemic shock. When pulmonary blood flow is reduced, they present with severe cyanosis or with duct-dependent pulmonary blood flow. Heart failure can actually ensue in this patient if intervention is not being taken care of. So the ECG is highly variable. We have ventricular hypertrophy depending on the dormant ventricle. If it's the left ventricle, you notice that you have left ventricular hypertrophy. If the right ventricle, the dormant ventricle, you have features suggestive of right ventricular hypertrophy. And the chest radiograph is similarly variable and then is rarely diagnostic. So this is what the echographic picture looks like of a patient with double inlet congenital heart disease. So if you look very well, this is a right atrium, and then this is a left atrium. So this is the mitral valve emptying into the left ventricle, and then this is the tricuspid valve emptying into the left ventricle. But if you look very well somewhere here, you realize that there's a small chamber here which looks like a hypoplastic right ventricle. Okay, hypoplastic right ventricle. But if you look at the echocardiographic picture, it basically just showing us the left ventricle alone. It's not showing us any hypoplastic right ventricle. Right atrium, this is the left atrium, and then this is the tricuspid valve, and this is the mitral valve. All of these are empty.
Sorry for the break. Dr. Florence, I know you have two devices on.
Okay, I'm here. I want to share. I want to share my screen back.
Yes, we can see it. Thank you.
Okay. Okay, so this is basically what it looks like on echocardiographic picture. I'm not taking so much time. Okay, so the indications and the options for intervention. So here, there's also a room for the Norwood type of repair. I said the Norwood type of repair is actually an anastomosis of the pulmonary artery with the aorta, meaning that it takes blood, it makes sure that the blood from the right side, as in it makes sure that blood gets into the pulmonary vasculature, gets the blood oxygenated, and then sends it into the systemic circulation to reduce that cyanotic effect that the patient has due to reduced concentrated oxygen in the blood sent to the systemic circulation. So the Norwood type of repair is actually done at this point in time. The patient can also benefit from Glenn, of which we said that we anastomose the supravenous cava with the pulmonary artery so that this patient can get some oxygenated blood before it's then sent to the left side of the heart, and then the left side of the heart sends blood down into the systemic circulation. Then finally, the Fontaine procedure is the last procedure for this patient. So these are the procedures that these patients will benefit from: the Norwood type, the bidirectional gland, and then much later in life, the Fontaine procedure, when the pressure of the dormant part of the heart is high enough to send blood into the systemic circulation. So for follow-up, these patients would be reviewed frequently, and in the center, conversant with issues of the Fontaine operation. So now the next one is total anomalous pulmonary venous connection. So this basically is a situation where all the pulmonary veins drain into the left atrium. By right, as we all know how the circulation of blood goes, the right atrium, the right ventricle, the pulmonary artery, the lungs, the pulmonary vein, and then it goes into it goes into the left atrium. But in this case, what happens is that the pulmonary vein sends blood back into the right atrium. Instead of sending blood into the left atrium, the reverse is the case in total anomalous pulmonary venous connection. So the morphology, actually, we have anatomic varieties of TAPVs, which is subdivided into different things. We have the anomalous connection, where in most of the time we have the supradiaphragmatic type, of which there's connection of the vertical vein to the left brachiocephalic vein, and also we also have the left lateral vessel also draining. So basically what happens is that we have 4 vessels draining into the left atrium. We have the superior vena cava draining into the left atrium, draining into the right atrium, sorry. We also have the vertical vein draining into the right atrium, and also the pulmonary vein all draining into the right atrium. But the right thing that should have been done was for the pulmonary vein to drain into the left atrium, but at this point in time is draining into the right atrium. So that's basically what happens in total anomalous pulmonary venous connection. So okay, so for the natural history, most patients with TAPVCs have symptoms during the first year of life, and then they undergo repair, such that the entity is rarely seen in late adolescent and adult patients. So if it is the patient that has classic signs of an ASD, but with associated cyanosis, this becomes what a right to left shunting to the atrial level. So basically what happens here is that most times the body compensates and then does hard a shunt to try to compensate so that the oxygenated blood getting into the systemic circulation will be adequate enough so that the patient can be compatible with life at the moment before intervention is being taken care of. So ECG findings will actually reveal a right axis deviation. Why? Because the right side of the heart is what is taking all of the blood, as in all the blood vessels are getting into the right atrium. So we have pictures suggestive of the right side of the heart. So we have right axis deviation, right atrial enlargement, right ventricular hypertrophy, because the right of the heart is now the dormant part of the heart due to the blood vessel being taken into the right atrium. So chest X-ray is actually would reveal cardiomegaly, and then it's also some increased vascular pulmonary vasculature if the patient is in heart failure. They can also present what we call the figure 8 or the snowman sign. So here the heart is said to be enlarged, and then with presence of what's right superior vena cava, inanimate vein, and then left ventricular vein all drain into the right chamber of the heart. So it then gives the heart that figure 8 kind of picture. You know, previously the heart is tilted more to the left. So now the right side of the heart is more affected. So you now have that figure 8 shape, meaning that the right atrium is then enlarged. I know we have the aorta bulging towards the left. So at this point in time, the right side of the heart is enlarged. So we then have that figure 8 feature because the right side of the heart is enlarged, looking like the normal side of the heart when it is normal, it looks more tilted towards the left. So it gives us that figure 8 kind of picture, and then the snowman kind of picture. Then echocardiographic picture will just show us features suggestive of right ventricular hypertrophy, features suggestive of right atrial enlargement. So this is what the picture looks like on this is the gross picture. If you look very well, the right atrium looks enlarged here, and this is the color Doppler. So if you look very well, the vein is actually draining into the right atrium here. So basically, that is what it looks like on the echocardiographic picture. Then MRI will actually delineate the site of connection of these TAPVs. And then you show the and then detect stenosis in post-operative patients. Then intervention surgery usually is performed during childhood and most often at presentation. So normally what we do is a sutureless technique. That's what is actually done in this case, where the pulmonary vein is actually opened widely into the retroatrial space. So this has markedly improved the results of such procedure. So basically, the pulmonary artery will now be diverted from the right atrium down into the retroatrial space. And this has been said to yield a good result thereafter. So in following up this patient, we have to do an early follow-up, which should be frequent and then aimed at early detection of stenosis of the pulmonary veins or the surgical anastomosis. So if not present within the first year, stenosis is actually rare. So another cyanotic heart disease, the pulmonary atresia with VSD. So basically, as I mentioned earlier on, pulmonary atresia, the valve is completely stenosed. So, or the valve is completely hypoplastic. So basically what happens here is that we said that pulmonary artery and VSD patients actually share the intracardiac anatomy of TOF, but there's lack of direct communication between the right ventricle and the pulmonary arteries. So basically what happens is that they just have the pulmonary stenosis, the VSD, and then over time they'll present with right ventricular hypertrophy due to the backflow of blood from an atretic pulmonary valve. So what happens is that they can present with pulmonary atresia and then VSD. So it has been attributed to chromosomal effects from microdeletion of chromosome 12 at shorthand 11. And then normally they present with facial abnormalities, nasal speech, and then developmental delay. So the pulmonary artery supply varies in pulmonary atresia and VSD. So that's basically what happens in a pulmonary atresia with the VSD. It just shows a picture like that of the TOF. So now we have three patterns of the pulmonary arteries. We have the unifocular, we have the multifocular, and then we have the multifocular with the non-confluent. So for the unifocular, normally what happens is that with confluent, we have a good sized pulmonary artery, which is supplied by the PDA. While the multifocal, we have a good confluent, but it's actually hypoplastic. We have a hypoplastic pulmonary artery that presents with what we call the seagull appearance. And then it's supplied by what we call the major aortopulmonary collateral arteries. So patients with the confluent good size pulmonary artery and stenosis and the pulmonary trunk, normally what happens is that they're actually suitable for fallow-like repair using a transannular patch to widen the right ventricular outflow tract. But patients with a good size PAS, but without the pulmonary trunk, would undergo a repair with a right ventricular to pulmonary artery conduit. So at adult age, clinical presentations for repaired patients is similar to that of TOF, as I mentioned earlier. Cyanosis will eventually lead to multi-organ involvement. A number of complications can occur in unrepaired patients. So they present with hemoptysis, which may be due to rupture of the small collateral vessels or due to small pulmonary artery thrombosis. They can also come down with features of chronic heart failure, if not well delved into. They can present with progressive dilatation of the ascending aorta, endocarditis, arrhythmias, and then sudden death, although not so common in these patients. Then the clinical findings, they present with cyanosis, continuous murmur. Chest X-ray will present with that of the boot-shaped heart contour. Echocardiography is going to show absence of direct flow from the right ventricle to the pulmonary artery. there's also a room for cardiac magnetic resonance, the CCT, the cardiac catheterization. These have been said to determine the source of pulmonary blood flow supply, and then the size of the pulmonary arteries to assess the major pulmonary collateral arteries, and then to obtain hemodynamics in these patients. So for the surgical intervention in these patients, so basically they'll actually need a ballooning and dilatation of the stent, as in meaning that since it is atretic, the patient will benefit from what we call ballooning dilatation to help to make the pulmonary valve patent, so that blood can get into the left side of the heart, and then blood is sent into the systemic circulation as well. So that's basically what is required for a patient with this heart defect. Okay, so now the next is transposition of great arteries. The transposition of great arteries actually is characterized by... Yeah, hello?
Well done, ma. Please, how many more slides do you have?
Okay, let me check.
Yeah.
What happens is that, by rights, the aorta is supposed to transverse from the left ventricle, and then the pulmonary artery from the right ventricle, but the reverse is the case in this situation. So what happens is that the pulmonary artery is found at the left ventricle, and the aorta is found at the right ventricle. So basically what they do for this patient is an atrial switch transition to atrial switch procedure. And this is what they use here is called the Wrestling type kind of repair in this patient. So in a patient with transposition of great arteries, is the atrial switch. They actually switch the arteries, like they send the pulmonary artery back to where it's supposed to be. That's the right ventricle, and then the aorta is sent to the left ventricle. So that's basically what they do. So they do a switch transition to the atrial switch procedure using the Wrestling type kind of repair, and it's said to be commoner in males than in females. So this is a picture of the patient with that, and this is also a picture of a patient with the same condition. Okay, so let me go. So much. So, okay, so we have the aortic arc interruption. This is not so common. So, okay, so let me go to Epstein's abnormality. It's also part of the cyanotic heart disease. But I think we have a good idea of that. Abnormality has got to do with the apical displacement of the septal tricuspid leaflet in conjunction with the leaflet dysplasia. So basically what happens abnormally is that the anterior leaflet of the tricuspid valve is actually not affected. But what is affected is the posterior leaflet, and the septal leaflet is what is being affected. There's supposed to be what we call unfolding or resorption. Okay, so basically what happens is that in the embryological development of septal valve leaflet, what happens is that there's what we call the apical portion of the valve normally undergoes what we call resorption, but there's failure this resorption to occur at the septal and at the posterior leaflet of the tricuspid valve. So what happens is that the apical and the posterior leaflet of the tricuspid valve is then placed apically. That's the septal and the posterior leaflet of the tricuspid valve is then displaced apically. So what happens is that the anterior leaflet of the tricuspid valve remains at the annulus where it's supposed to be, and then because the septal and the posterior leaflet of the tricuspid valve is displaced apically, it doesn't coapt. That's the valves don't coapt the way it should be. So what happens is now what atrialization. Well, and then they also present with cyanosis in this patient, and then what happens? They become breathless, And so what happens is that with severe tricuspid valve deformity, newborns and infants actually present with failure to thrive, and they present with what we call the right-sided congestive heart failure. Children who present after neonatal period remain asymptomatic until late adolescent or early adult life. So most times they present with heart failure, they present with palpitations and all with tricuspid, and depending on the severity of the tricuspid regurgitation, that now depends on how severe the disease condition will present. So ECG findings will just present with low voltage ECG. You see right atrial enlargement, features suggest right atrial enlargement, atrial flutter. Echocardiography will simply just show apical displacement of the septal leaflets of the tricuspid valve. Then the size of the atrium will be, there'll be the size of the ventricle will be atrialized. It will not be walking like the atrium instead of walking like the ventricle itself. Then the echocardiography will tell us the extent of tricuspid regurgitation in this patient. So indication for intervention for this patient is cyanosed, patient is in right heart failure, poor functional capacity, occasional paroxysmal emboli, and then which patient has supraventricular arrhythmias, which is a common kind of arrhythmias that presents with recurrence. This patient will actually need medical or ablation therapy, and then they would benefit from a tricuspid valve repair in this patient, which would involve a bidirectional. They also benefit. And then there's also a room for catheter ablation. This patient has been having recurrent arrhythmias. So an atrial communication, if present, should be closed. In occasional patients with a resting oxygen saturation of more than 90% and exercise intolerance caused by worsening hypoxia, closure of the patent foramen ovale or ASD may be indicated without addressing the tricuspid valve itself. So reproductive issues. In the absence of maternal cyanosis, right-sided heart failure, arrhythmias, pregnancy is usually well tolerated. In follow-up, all patients with Epstein abnormality should have regular follow-up. The frequency being detected for by the severity of the disease. Particular attention should be paid to patients with cyanosis. Then patients with substantial regurgitation following tricuspid repair would need a close follow-up as the patient do not present with recurrent atrial arrhythmias, degenerative prosthesis, or dysfunctional mechanical valves. Thank you. Ah, good. Thank you. I'm done.
Well done, Dr. Florence. Yes. Chief Okopi, please continue, sir.
No, I just want to say thank you, for all the effort she put into making these slides and this presentation. Thank you so much. Well done. Very excellent.
Thank you, sir.
Thank you very much, sir. Dr. Florence, thank you so much once again. Please, participants, Chief, please, is there any question, addition, or comment? Thank you. Well, everybody is giving you accolades. Thank you so much. It's a well presentation, Dr. Florence.
Thank you.
Please, if you have any comments or contribution, kindly let us know before we move to the next session. Thank you. Dr. Florence, thank you so much. Since there are no questions or comments.
It's dominant. Dominant.
As in which one is dominant? Okay, it seems as if you've covered everything. Thank you so much, Ma. So I don't know if you can kindly unshare and we go to the next session, Prof MCQ. But please, we'll also need somebody to share Prof MCQ for us. Dr. Alagbe, are you ready to take your part on Prof MCQ? Sorry, the reshared part. Dr. Alagbe?
Yes, I'm
she's not
ready.
Here. Okay. All right, thank you, ma'am. So we just wait for somebody to help us share. Or can you please kindly help us share the book?
Okay, let me look
Thank
for
you.
it.
Wow. Thank you, ma'am. Or if there's any other person that can easily get access to the book to save time. Thank you so much. Chief Kawasa, we appreciate you helping us to record. Thank you, sir.
Sorry, I didn't hear what you said.
I was thanking you for helping us to record, sir. Thank you very much.
Oh, okay. Sorry, I am still trying to step back to the class.
Dr. Alagbeofa, oh, please, does anybody have the book and can easily access it so that we can?
I'm sharing right away.
All right, thank you, ma'am.
Make a short contribution before the slide book comes up. So for tetralogy of Fallot, although I don't think anybody has difficulty remembering the components, but two of the components are anatomical. That is the pulmonary stenosis and the large non-restrictive VSD. So the remaining two are a consequence of these first two anatomical abnormalities. So the very large non-restrictive VSD causes the overriding of the aorta, such that it sits over the VSD and takes blood from both ventricles. Then the RVH is a result of the pulmonary stenosis. If we remember that the heart starts beating in utero from the first trimester. So just thought that may be helpful. Thank you.
Thank you.
Thank you, ma'am. Please, any other comments before we start talk? Chief Alagbe, you can start, ma'am. Thank you, ma'am.
Okay, section C20, number 26. E, polymorphic. C, to start the point. B, bidirectional. E, right to left bundle branch pattern. So what the STEM question is just trying to describe is actually to start the point. That's saying that when the wave contour vary in a more or less repetitive manner, that's the spinning pattern. That's what it's just trying to describe. So that's to start the point. If we remember, was it yesterday or the day before yesterday, then the bidirectional one would be that it varies in QRS axis. As one is positive, the other one is negative, then it keeps alternating like that. That's bidirectional. But for to start the point, it varies in a repetitive manner, like it's spinning around the point. So that's 26. Then 27, it says one of these supports supraventricular tachycardia as opposed to ventricular tachycardia.
No, please.
Okay.
Please, ma'am, can I ask a question?
Okay, sir.
Hello, I don't know if I'm audible.
Yeah, you're audible.
Okay, thank you, ma'am. Thank you. I'm just wondering why the bidirectional
Yeah.
is not also for consideration, because it also varies in a repetitive manner. Because you see the QRS up now, the next one is down, up, down. So what is it exactly that makes you think that it is torsades?
Okay. For bidirectional, the variation is in QRS axis. For example, the first axis will be positive, the next one will be negative, the next one will be positive, the next one will be negative. So the axis varies. But this one, he's saying the QRS wave contour varies in a repetitive manner.
Yeah, you've hit the nail on the head for me. Thank you.
Yeah, you're welcome. 27. One of these supports supraventricular tachycardia as opposed to ventricular tachycardia. So we know that ventricular tachycardia, there are some features that you see, and you know that this is ventricular tachycardia as opposed to supraventricular tachycardia. Things like fusion beats, capture beats, compensatory pulse, then activation of the ventricle with retrograde activation of the atrium, and then negative QRS complex in the precordial leads or even in leads 1 to 3. Those are things that suggest ventricular tachycardia. So now, option A, fusion beat is true. It supports ventricular tachycardia. Caption beat is true. It supports ventricular tachycardia. P and QRS rate and reading when linked suggests that atrial activation depends on ventricular discharge. This is also true for ventricular tachycardia because the discharge is coming first from the ventricle. Then long short cycle sequence. Okay, I don't really understand what this means, but what I'm thinking is maybe that Asherman phenomenon that we see in atrial fibrillation with PVCs. So you have a long RR interval, then a short RR interval, then an aberrant conducted wave. So that's what I'm thinking is this long short cycle sequence. So that one is for a supraventricular tachycardia. Then compensatory pulse. This is also in support of VT. So the odd one in support of supraventricular tachycardia will be long short cycle sequence. Any comments, please? Okay. 28. In our environment, which of these is most commonly associated with symptomatic ventricular tachycardia? Ischemic heart disease, cardiomyopathies, mitral valve prolapse, valvular heart disease, adult congenital heart disease. Okay. It's said that in Western world, that's in developed countries, the commonest cause of their VT is actually ischemic cardiomyopathy. But in our environment, it's due to cardiomyopathies, maybe either dilated cardiomyopathy, alcohol-related cardiomyopathy, cardiomyopathies from different causes, actually. But in Western world, most times their symptomatic VT is as a result of ischemic heart disease. So that's why B is the correct option here. That's in our own environment because we have lots and lots of causes of cardiomyopathies. Any comments? Okay. 29. Which of these tachyarrhythmias cannot be treated by rapid burst temporary pacing? So this question is asking us about indications for transvenous temporary pacing. So what I read is that you can actually use pacing to detect or terminate tachycardias. And you can use this for some wide complex tachycardia like non-sustained VT. Then you can also use it for supraventricular tachycardia like atrial flutter and paroxysmal supraventricular tachycardia. But from what I checked, usually for atrial fibrillation alone, you can't use it, except there's atrial fibrillation with bradycardia. Then you'll be able to use this temporary pacing. But if it's just straightforward atrial fibrillation, you can't use it because it will not even help in treating it. It will still revert back to the AF reading. But if it's existing with bradycardia, yes, it can help. But the ones that you can use temporary pacing to treat, you can use it for atrial fibrillation, you can use it for supraventricular tachycardia, and we know that atrioventricular nodal tachycardia is a form of supraventricular tachycardia, and you can also use it for sustained VT. Any comments? Okay. 30. Pacing is rarely necessary in complete AV block with stable hemodynamics. On the other hand, pacing may be indicated with all but one of these. Okay, sincerely speaking, I didn't understand this question in the sense that from the guidelines, complete AV block, whether symptomatic or not symptomatic, is an indication for pacing, according to guidelines. So I didn't really understand this. Pacing is rarely necessary in complete AV block with stable hemodynamics, because what I came across in the guideline is whether there's symptom or there's no symptom, so long as a third degree AV block, complete AV block, you should pace the patient. Then second degree Mobitz type 2 with symptoms, pace the patient. So I don't really get this thing. But he said on the other hand, pacing may be indicated with all of this. So I think he's asking for the question is asking for symptoms that can be associated with third degree AV block that can make you pace. So if they have congestive cardiac failure, yes, you want to pace. If they have hypoperfusion from the cardiac failure, you pace. If they have hypotension, you pace. Then also, if they have coexisting ventricular arrhythmias, you will pace. Then option E, minimal reduction in ventricular rates. I didn't see anything like that. Minimal reduction in what sense? So E is the wrong option. Please, any comments? Okay. Please, am I audible?
I don't think there's any Yes, you are audible. I think it's just to come and continue.
Yes.
And Chief Ukopia have said so. Because like you said, any complete heart block, you have to pay. So what do they mean by minimal reduction in ventricular rate? What's the definition of minimal reduction? You know?
Because normally ventricular rate is already, most times is reduced. That's under normal condition. It should be like around 40. So what are you trying to, I don't understand. Okay, but let's just take note that in AV block, whether there's symptom or not, whether they're hemodynamically stable or not, there's a class 1 recommendation that you should pace the patient.
Yes, ma'am. Then maybe we'll also note the question for Prof. It's going to take us pacing some, so maybe it will also help. Thank you very much, ma'am.
You're welcome. 31. One of these is not a secondary form of pulseless electrical activity. So what is pulseless electrical activity? We know that that's one of the electrical activity that we don't defibrillate together with a systole, and is also known as electrical mechanical dissociation. So from the name, in this kind of rhythm, there's the electrical activity that is normal, but there is no contraction. So the conduction system are intact and they are sending impulse to the myocardium, but the myocardium is not contracting. So that is also called electromechanical dissociation. Sorry. So what are the causes of pulseless electric activity? So they said it can be primary, it can be secondary. Primary is when there's an intrinsic problem with the heart, but most times the causes of pulse electric activity are secondary. That's when there's an extrinsic cause. And the extrinsic causes are the 5H and the 5T. So the 5H, sorry, let me show the options so that as I'm calling them out then. So the 5H, we have hypovolemia, we have hypoxia, we have hydrogen ions, that's increased hydrogen ions, that's acidosis. Then we have hyperkalemia, we have hypotemia. Then the 5Ts, tension pneumothorax, trauma, tamponade, thrombosis of pulmonary origin, then thrombosis of coronary origin. So now when we come here, option A, massive pulmonary embolism, that's under one of these, thrombosis from pulmonary origin. Exsanguination is a form of, it causes hypoxia, so is one of the H. Then end stage heart failure, let's keep that. Then acute malfunction of prosthetic valve. Indirectly, when they malfunction, they can lead to hypovolemia. For example, if there's a regurgitation, the cardiac output is going to, it can decrease the stroke volume, then the heart will perceive it as hypovolemia. Then cardiac tamponade is one of the T's. So the wrong option here is end-stage heart failure. It's not part of the secondary causes pulseless electrical activity. Okay. 32. Mechanisms of cardiac arrest vary. The most common being ventricular fibrillation. Which one of the following is a common mechanism? Bradyarrhythmia, electromechanical dissociation, rupture of the ventricle, cardiac tamponade, acute mechanical obstruction to flow. Sincerely speaking, I was trying to search for this. I didn't really see anything that was making sense to me. But I know when I saw an article that said bradycardia with reduced heart rate of less than 60 can result in lethal ventricular arrhythmias during various stages of myocardial MI. So that's what I saw. But from Prof's book, the answer is bradyarrhythmia. Please, any comments or any explanation to the answer, if someone can help.
Hello.
Hello. Yeah.
Yeah,
Good evening.
this be electromechanical dissociation. It's like another term for pulseless electrical activity, not so.
Yes, that's the other name.
And when you look at the causes of cardiac arrest, pulseless electrical activity comes higher than bradycardia. So if you're looking at it from that angle, the pulseless, because he has put the most common to be ventricular fibrillation. And I think, yeah, in terms of the other abnormalities, pulseless electrical activity comes before bradyarrhythmias. But bradyarrhythmia is among the least.
Okay. Oh, okay. What me I was even thinking was that maybe the bradyarrhythmia will cause ventricular fibrillation. That was how I interpreted the question, that which one of the following is a common mechanism? That's common mechanism of the VFib. That was what I was thinking. But now with this explanation, actually, yes, after PEA is the next.
Yeah. You know that the bradyarrhythmias, they are also a separate cause of cardiac arrest. Because when you get, especially with the AV blocks, and those are the ones you have to be transcutaneous spacing for. And they come down in the list of, common causes of arrest. Yeah.
Yes, they are down. Okay. So maybe we can still take note of it and ask a senior person or something. Okay. Thank you, Dr. Conte. Okay. Digoxin toxicity in cardiac amyloidosis is due to A, associated nephrotoxic syndrome, B, decreased excretion through the kidneys, C, dyselectrolytemia, D, high affinity of drug binding to amyloid fibrils, E, high serum level attained in this disease. Okay. They said in cardiac amyloidosis, actually, it's not advisable to use inotropes in them, because it further worsens their LV function. And then a study that I came across actually said that the toxicity in them is potentiated by binding of the drug to the amyloid fibrils. So D is the correct option. Please, any comments? No comments. 2, which of these approaches enhances depressor influences as part of treatment of essential hypertension? So the question is just asking depressor influences, that's which of these will help in lowering the sympathetic output in order to help in the treatment of essential hypertension. So A, addition of antagonists of endothelin receptors. We know that endothelin 1 is a potent vasoconstrictor. So they are saying addition of antagonists of endothelin receptors. B, field electrical stimulation of carotid baroreceptors. We know that the carotid baroreceptors, they tend to sense both increase in blood pressure and decrease in blood pressure. So depending on the state of the vessels, if the BP is increased and you stimulate them, it's going to decrease the BP. Then if the BP is increased and you stimulate them, if the BP is decreased and you stimulate them, it's going to increase the BP. Unlike the aortic baroreceptors, they only sense increased blood pressure. They don't have that dual sensing of both low BP and high BP. They only sense high BP and then try to reduce it. So I came across a study where they used this field electrical stimulation of the carotid baroreceptors to treat resistant hypertension. So option B is the correct one, but let me go on. Then introduction of an anti-aldosterone agent. That will also bring down the BP. But the depressor effect now that they are trying to say here is, from my understanding, is something that has direct effect on the sympathetic outflow. So this field electrical stimulation is going to cause inhibition of sympathetic outflow, thereby reducing the BP. Then D, radiofrequency denervation of the kidney, and E, surgical denervation of the kidneys. The study I came across actually stated just the way the question is: field electrical stimulation of carotid baroreceptor as a depressor in treatment of resistant hypertension. I think that was the article I saw. So the answer is B. I don't know. Any comments? Any contribution? The last question. Which of these drugs affects digoxin metabolism by mechanisms other than renal clearance? Okay. Most of these drugs, amiodarone decreases clearance of digoxin. They have an interaction, so it decreases renal clearance of digoxin, thereby potentiating digoxin toxicity. Then quinidine also does the same thing. I didn't see anything about verapamil, and I didn't see anything about verapamil and spironolactone. But from his answer, the answer is cholestyramine. Also, I didn't see how it does that. But I know the drugs I saw that affect renal clearance of digoxin. I saw amiodarone, I saw quinidine. But his answer is cholestyramine.
Okay. Hello, ma.
Yes,
Something.
please do.
If I recall correctly, verapamil, amiodarone, quinidine, they do similar things. They reduce the renal clearance of digoxin and can lead to digoxin toxicity.
Okay.
You understand? So
yes.
I can't remember this issue of cholestyramine, but I know those other three, they do the same thing. So I'm trying to check cholestyramine.
Okay, I'm seeing something now. They said cholestyramine is likely to be a weak digoxin binder in the guts. So it binds to digoxin. It binds to digoxin in the guts. So that's how it affects its metabolism.
Okay, so it reduces the availability of digoxin.
Yes, that's what it does. Because previously I just checked digoxin metabolism. No, digoxin interaction with other drugs. So I didn't see cholestyramine. I just saw those ones you called. But now I just typed digoxin and cholestyramine. So I saw that cholestyramine is likely to be a weak digoxin binder in the gut. And that changes induce this rising in digoxin metabolism. Okay, another one said serum digoxin concentration rapidly decline when co-administered with cholestyramine. So I think cholestyramine is like a resin that binds digoxin, so it will decrease the availability of digoxin. Thank you. That's the end.
All right. All right.
Okay, Doctor.
Thank you very much,
I think you're
Chief.
done.
Yes, thank you so much. I don't know whether Dr. Oji is on the call. Dr. Oji. Dr. Ozuke, please, are you there? Okay, it's there, but maybe it's not close to his phone.
Hello.
Okay.
Maybe I can
Hello,
be doing mine while we wait for the next person.
Yes, there's Dr. Oji. Dr. Ozuke is supposed to be a backup for him, but maybe it's not close to his phone. Yes, Dr. Conte, you can take your part.
So it's section F. It's from question 7 to 16. Can we move to section F?
Please, can you tell me the page? It's better to look
50,
for it.
52, 52, yeah, 52.
Okay.
All right. So question 7, that's where I'm starting. Okay. So question 7 says regarding Cone syndrome. So Cone syndrome is basically hyperaldosteronism. Yeah, so generally there are two major pathologies that account for over 90% of hyperaldosteronism. Either is adrenal adenoma or bilateral adrenal hyperplasia. So generally, these are the patients who present with hypertension with hypokalemia as a result of excess aldosterone secretion. One of the things they notice that their presentation can be very, very non-specific. So you have to suspect and then investigate patients who come with difficult to control blood pressure. You know, sometimes they can, even the hypokalemia can be so mild that you can miss it. And then they have high aldosterone level and also high renin level. Or when you do the aldosterone-renin ratio, say a ratio of about 30:1 is usually sort of specific for hyperaldosteronism. So generally, especially when they have adrenal adenoma or hyperplasia, high resolution CT scan is what is preferred for, imaging, and is what is being used most commonly. And then for the adrenal adenoma, the treatment of choice is surgery. You have to do surgical resection of the adenoma. Whereas when you have the bilateral adrenal hyperplasia, it's medical therapy, and mainly with aldosterone antagonist, in addition to other antihypertensives. All right, let's look at the options. So it says, regarding Cone syndrome, there is typically presence of edema. All right. The next option says absence of hypokalemic metabolic acidosis eliminates its diagnosis. Okay, that is not true. MRI is better than CT scan to diagnose. That is also not true. Medical management is preferred in idiopathic adrenal hyperplasia variant. Yes, that is true. That's correct. Presentation is with distinctive features. The presentation, as we said, can be very non-specific. And so the the correct, the true answer there is D. Medical management is what is preferred when you have idiopathic adrenal hyperplasia. Okay. The next question, or any comments? Can you scroll up to question 8, please? All right. Regarding non-pharmacological management of hypertension, which one of these is accurate? A, reducing salt intake is more relevant in young than the middle-aged and elderly. Okay, we'll just go through them. Weight management could drop blood pressure by 5 to 20 millimeters of mercury with 10 kg of weight loss in hypertensives who are obese. Okay, C, dietary manipulation is inappropriate in hypertensive diabetic. And then D, increased intake of cations potentiates the effect of sodium on blood pressure. And E, minimizing smoking as for alcohol intake is inappropriate for blood pressure. So I think in one of our meetings, I posted the recommendation, small diagram that shows the recommendations for non-pharmacological management. And for this question, the answer is B, which is actually a direct copy of what is in that picture that I posted, that with a 10 kilogram loss, you reduce the blood pressure by 5 to 15 millimeters of mercury. I think that table was taken from one of the earlier ESC guidelines on hypertension. Now, looking at the other option, so if we start with D, minimizing smoking as for alcohol intake is appropriate. Of course, we know that the recommendation for smoking is to quit, not to minimize, as is being purported for alcohol in the previous guidelines. Okay, but we know now that the World Heart Federation is now actually pushing for quitting alcohol as well, the same way you quit cigarettes. But as for the time of this book, so for alcohol it was to reduce it, and then for cigarettes is complete abstinence. The other question, the increased intake of cations potentiates the effects of potassium. That is not correct at all. For instance, taking cation like potassium, okay, actually has a lowering effect on blood pressure. Okay, its effect on blood pressure is opposite that of sodium. So not taking in cation does not potentiate the effect of sodium on the blood pressure. Then C, dietary manipulation is inappropriate in hypertensive diabetes. Of course, that is false. Diabetic who are hypertensive, in fact, need dietary manipulation to control their sugar, also control their weight. Okay, and that will help control their blood pressure. And then the A question, reducing salt intake is more relevant in young than in middle and up. It's actually relevant in all age group, okay, and not just in the young. Okay. So any contribution towards that? So question 9. Which of the following is true of hypertension? Okay. A, the presence of LVH, despite normal or borderline blood pressure, calls for pharmacotherapy. Okay. Office blood pressure measurements more accurately predict cardiovascular risk than out-of-office blood pressure measurements. Primary and secondary hypertension are of equal burden in the affliction and in the afflicted population. The monotherapy with thiazide or calcium channel blocker is ideal as initial therapy for patients with blood pressure 20/10 millimeters of mercury above target. Gender is of no consequence in the etiopathogenesis of BP. Okay, so I think we did the hypertension guideline recently, and this question is answered basically from that presentation. So for the A option, which is the correct option, you remember that if the person has sign of target organ damage, okay, that can be a compelling reason to start antihypertensive, even if the blood pressure is in the high normal range or normal. Once they have evidence of end organ damage secondary to hypertension, is an indication to start pharmacotherapy. Now, the other option, office blood pressure measurement, is more accurate, of course. We know there can be white coat hypertension. You can get mask hypertension. If you can miss mask hypertension if you rely on office blood pressure measurement. So the BP monitoring out of office is more reliable to pick up those sort of patients. And then C, primary and secondary hypertension are of equal burden. Of course, we know that primary hypertension is the common one, as opposed to secondary. Monotherapy with thiazides or calcium channel blocker is ideal. So we know that the target generally for blood pressure control is less than 140/90. So if you add 20 to 140, that will take systolic to 160. And if you add 10 to the 90, it will take the systolic to 100. So that puts the person straight away at stage 2 hypertension. And from what we discussed, when the person is at stage 2 hypertension and you're going to start treatment, they are advising that you go for the two drugs, and preferably the fixed dose combination medication to treat person at stage 2 hypertension. Okay. E, gender is of no consequence. Of course, one of the risk factors for essential hypertension is gender. So the male gender, they have a higher risk of developing than female. Any comments? Okay, number 10. All right. So number 10, which of the following is least likely to affect routine blood pressure measurement? Okay. This one, we have to go with what Prof says. Because when I look at all the things that are listed, they all seem to have effect on blood pressure. So the first one is the office setting. Of course, we know a lot of people, when they are in the hospital or clinic area, they get anxious and you can get erroneous reading. So the office setting affects blood pressure measurement. Then night timing. Okay. We all know that there is a diurnal variation in blood pressure. Okay. And the blood pressure tends to drop to the lowest at night when the person is sleeping. Okay. And of course, towards the later part of the day, we know that the blood pressure goes lower compared to when you just wake up. Because of the hormonal changes, the blood pressure tends to rise. So based on that, you would expect that to affect blood pressure, according to my own reasoning. The next one is clinician observer. Of course, it depends on the skills of the person who is recording the blood pressure. Okay. And you get a first-year nurse who is just practicing. The reading you get will be different from a medical officer or a senior nurse who has been measuring blood pressure for a while. And then the oscillometric device, so the aneroid speed. Of course, we know that in terms of the machines, the mercury sphygmomanometer is one that is said to be the most accurate. Okay, the aneroid speed can have some error sometimes. Especially if you pay attention to the oscillometer rather than listening for the sound, you can get erroneous readings from that as well. And then also problems with calibration of the oscillometer can arise as well. Full bladder status, because when the bladder is full, the urge is to void, which is a parasympathetic effect. And when you try to suppress that by activating the sphincter, you have to use sympathetic stimulation. And so once you have that generalized stimulation, as you control voiding of the bladder, it also causes peripheral vasoconstriction, heart rate goes up, blood pressure will go up. Okay, so when you have a full bladder, because of the sympathetic release to maintain the sphincter tone, then the blood pressure will go up. Yes, all that said, according to the author of the book, the answer is B. Say B has the night timing has the least effect on the blood pressure. Although, well, so maybe you could agree. I could not see any research that has been done because he's asking for the least effect, not that night timing does not have an effect, but according to him is what has the least effect on routine blood pressure measurement. Any comments or addition?
Yes, I want to believe that the distinctive word there is the word routine blood pressure measurements, which apparently implies that if one maintains nighttime as a period of measuring his blood pressure, even that this it will give a consistent pattern of reading. So that's routine is what may bring in the difference. It has to do with timing. The office setting has nothing to do with timing. Clinician observer, oscillometry, full bladder can occur at any time. So I think that may be the reason why that's nighttime. Nighttime may be the right option.
Okay, I get your argument, but then you can extend that same argument to the oscillometric device, because if you stick to it and you are using it alone, then it will give you, a consistent reading every time. Just as the same way.
The oscillometric device is subjective. 3 different persons may get different oscillometric recording.
Okay. So anyway, we have.
Okay, sorry. Another way that I was looking at the question was, I was thinking that office setting, most times maybe it will increase the BP. Clinician observer, I felt it can also increase. Oscillometry can increase. Full bladder will definitely increase. So I felt night timing will give you a reduced reading. So that's the one that is looking odd out of it. That's how I even looked at it.
I don't know. Why will clinician observer give you high reading? They can give you erroneous low reading, depending on who measure.
Okay, sure, that's true.
Yeah. So anyway, at least most of the things that affect the BP are in this question, and it has told us that the one that least affected is the night time. So at some point we have to accept it like that. All right. If there are no further comments, we move to question 11. So question 11 says, which of the following does not apply to salt-sensitive hypertension? Okay. So this salt-sensitive hypertension is a topical issue, and a lot of putative mechanisms, a lot of systems involved in this salt-sensitive hypertension. But what is the central theme is that you have certain people who, when they take in a load of salt, it causes a significant increase in the blood pressure. And if you give them diuretics that cause them to excrete sodium and water, within a 24-hour period, you can actually measure a significant drop in the blood pressure. And these patients generally tend to have relatively low renin level, and the response of the RAS system to sodium load is sort of blunted. So because normally when you get a sodium load, your renin secretion should drop so that you reduce production of aldosterone and then you excrete sodium. Okay, and then the opposite happens when you have low sodium intake. So the renin secretion should go up, help you retain sodium. So in people with salt-sensitive hypertension, they have basal renin levels that are low, and the response of the RAS system to sodium load is reduced. And so they have changes in their blood, significant changes in their blood pressure when they take in, sodium high salt diet. So looking at the option, they say the prevalence is increased in which one does not apply. So we are looking for the false answer. The prevalence is increased in African Americans. So that is true. In Black people generally, they tend to have this high prevalence of salt-sensitive hypertension. The rate of macroalbuminuria is exaggerated. That is also true. So the renal, they tend to develop, hypertensive nephropathy at a faster rate compared to those without salt-sensitive hypertension. Plasma endothelin level are increased. That is also true. And then the E option, it is related to nutritional calcium deficiency. So they've also shown that these patients with salt-sensitive hypertension, their calcium and magnesium level tend to be on the low side. Okay, and some are, especially when they've seen it among Blacks, they are saying might be as a result of nutritional deficiency in finding underprivileged population. All those are putative mechanisms. I'll try to share one of the documents that I read. It's a lot, but they are all just what are called putative mechanisms. So the option D, which is the answer, says the half-life of urine sodium excretion is shortened. So generally, their excretion of sodium, the renal excretion of sodium is less compared to people without salt-sensitive hypertension. Because as we said, the intake of salt does not produce significant changes in the RAS system. So that effect of dropping the renin-angiotensin secretion to allow excretion of sodium does not happen. So they tend to excrete sodium slower compared to people who do not have salt-sensitive hypertension. So the answer for this one is D. Any further comments? Okay, number 12. Hello? Can you scroll please to number 12? All right. This one is the one that I have problem with. So which of these retinal changes is relatively specific for hypertension? I try to search for specific retinal changes in hypertension. The things that I come across, they'll just give you all the stages of hypertensive retinopathy, but do not come up with any one particular change that is specific for hypertension. I could not find any document in my search that really pointed to anyone as being specific for hypertension. So the options here, they have arterial macroaneurysm, cotton wool spots, flame-shaped hemorrhage, silver wiring. Okay. In the stagings the changes that I saw more of microaneurysms. I didn't come across these macro aneurysms in the retinal changes. For the cotton wool spots, flame-shaped hemorrhages, silver wiring is the first stage usually that you see. They're all there. Okay. But according to Prof, the answer to this question is A. I could not find evidence to support that. If anybody has any evidence concerning that one, I'm happy to learn.
Sorry, I'm searching something now that they said vaccinational atrial microaneurysms are seen in elderly with marked female preponderance and a strong association with hypertension and arteriosclerotic vascular changes. So I'm not seeing the word specific, but they said it has a strong association with hypertension and is seen in elderly female hypertensives, seen in 75% of patients.
Yeah, so in fact, that one is microaneurysm, you said, not so.
Macroaneurysm.
Okay.
Macroaneurysm, yes. I typed arterial macroaneurysm. So he said it's found in elderly female hypertensives and seen in 75% of them. And is a rare sign of systemic hypertension. So I think that's where the specific is coming from.
Oh, okay.
It's a rare
75%.
sign. Yes, is a rare sign of systemic hypertension that occurs in elderly female hypertensives.
All right, well, that's good. Thank you so much. I mean, please. Yeah, so arterial macroaneurysm, specific. In other words, high preponderance in hypertension. All right. Any further comments on this one? All right, 13. Say above 2 drinks a day, the higher the alcohol intake, the higher the blood pressure. One of these is not a putative pathogenic mechanism linking both, so linking blood pressure and alcohol. Okay, so A is neurohormonal activation, of course. High alcohol causes sympathetic, activation. B, activation of vascular relaxing substance. That will be false. I mean, vascular relaxing substance will cause vasodilatation and reduce your blood pressure. So that cannot be a mechanism of alcohol. Calcium depletion is true. As part of the diuretic effect you get with alcohol, it can cause calcium depletion and is being postulated as one of the mechanisms by which the blood pressure increases. Magnesium depletion as well. Increased acetaldehyde. It also happened. This one also has a lot of putative mechanism. I'll share some documents, but activation of vascular relaxing factor is odd among these options. So the answer to this question is B.
Sorry, please, I have a question with this calcium depletion, even the former one. I felt we use calcium channel blockers to treat hypertension. We are blocking the calcium. So if it's depleted, we should have a low BP. Why is it now giving high BP? My thoughts.
They have some elaborate explanation for the relation of calcium concentration, to high BP. I would have to look at it, but they put them as putative mechanism. That even in population where you have nutritional deficiency in calcium, magnesium, and even potassium, they tend to have higher blood pressure compared to people with, normal level of those cations. Okay. Question 14. Systolic murmurs had in hypertension could result from hypertensive hypertrophic cardiomyopathy, where the left ventricular cavity is small and left ventricular walls are hypertrophied with normal or hyperdynamic systolic function. Which antihypertensive class worsen this disorder? Okay, so this one, generally, in people with hypertrophic cardiomyopathy, you don't want to use this peripheral vasodilators, okay? Because what those, so when they reduce the peripheral vascular disease resistance, they tend to worsen the outflow tract obstruction, right? And then also, especially with those vasodilators that cause concomitant venodilatation, they reduce venous return. And you know, when you reduce venous return, it also tends to worsen the outflow tract obstruction because you reduce your end-diastolic volume, and that worsens outflow tract obstruction. So when you read some of the documents, so even the angiotensin receptor blockers, they are advised not to be used in patients because they are potent vasodilators, not to be used in patients with hypertrophic cardiomyopathy. Okay. The non-dihydropyridine calcium channel blockers can be used because of their rate controlling effect, so that they slow the rates and then improve diastolic filling. However, some literature will tell you because those calcium channel blockers, those non-dihydropyridine, you also have some vasodilatory effect. That vasodilatory effect tends to sort of counter their effect and tend not to affect, you know, the LVOT obstruction significantly because of the vasodilatation they cause. So here, in the options, we have other vasodilators, and then one of the options is the direct vasodilators. Okay, so if we go through the option A, the alpha blockers, generally these ones are not even used in hypertrophic cardiomyopathy. Okay, but we know that they will cause vasodilatation, you know, and from mechanism, they will worsen it. Beta blockers are the ones that are preferred to be used. After beta blockers, and then you have disopyramide, which can also be used in hypertrophic cardiomyopathy. And then the calcium channel blocker, as I said, the non-dihydropyridine calcium channel blockers, they have been used because of their rate controlling effects. So literature will tell you that you should be avoiding angiotensin converting angiotensin 2 receptor blockers. But from these options, what was chosen is the direct vasodilators. Okay, I don't know, because they are direct vasodilators, and then these other ones have vasodilatory effects. But when you look at the literature, the vasodilators are generally avoided in hypertrophic cardiomyopathy. So any contribution? Okay, moving on, question 15. When a pregnant woman is hypertensive, but normalizes by 12 weeks postpartum, with a potential to recur in subsequent pregnancy, predictive of future essential hypertension, that hypertension is described as A, chronic hypertension, B, chronic hypertension with superimposed preeclampsia, C, transient hypertension, D, preeclampsia, E, gestational hypertension. So this I think at some point before we had discussed this question. So the American Society of Obstetrician Gynecologists, they came out with some new classification of hypertension in pregnancy, wherein there are 4 classes: hypertension, preeclampsia, chronic hypertension, preeclampsia superimposed on chronic hypertension. And then the last one is gestational hypertension or transient hypertension in pregnancy. Now, that category, gestational hypertension or transient hypertension in pregnancy, it used to be called pregnancy-induced hypertension. Okay? But according to the College of Obstetrician and Gynecology, they now prefer to use the term gestational hypertension or transient hypertension of pregnancy. Okay, so which is what is described here. Basically, is a form of hypertension that occurs late in pregnancy. Okay, and then after the pregnancy, the person delivers, the blood pressure goes back to normal. All right. So we have, according to that latest classification, we have 2 options here that fit that answer: the transient hypertension and the gestational hypertension. But according to the book, it's the transient hypertension that was, picked as the correct option. So what are your opinions on this question?
I want to send something to the group now. I'm trying to send it. I just saw it online now. A document by the 7th report of GNC on prevention, detection, evaluation, and treatment of high blood pressure. There's actually like a picture titled transient hypertension, and they wrote bullet point 1, retrospective diagnosis. That's to make that's the criteria for transient hypertension. Retrospective diagnosis: BP normal by 12 weeks postpartum, may reoccur in subsequent pregnancy, predictive of future primary hypertension. So I feel this is where he got the question from, because it's all the criteria that he listed in the STEM question. So I'll put it on the WhatsApp page.
Okay.
It's by GNC 7.
Okay, thank you very much. Yeah. So it's just that in that other classification by the Society of Obstetrician Gynecologists, then they put gestational hypertension and transient hypertension of pregnancy as, as term used interchangeably for the same entity. Okay, thank you. Any other comments concerning this one? All right, 16. Liddle syndrome, a monogenic form of salt-sensitive hypertension. Of course, they are explained, caused by gain of function mutation in the epithelial sodium channel. So this is one of the secondary causes of hypertension that affects the sodium channels in the distal tubules and collecting duct. Okay, so they make those channels, they increase the function of those channels, make them resistant to clearance. So they are present in abundant amount and they absorb sodium into the system. So you end up with a hypernatremia and then hypertension, fluid retention as a result of that. It's very, it's sort of similar to hyperaldosteronism, in that you tend to get hypokalemia, okay, with hypertension. You can get metabolic alkalosis. However, the major difference is that in these patients with a genetic, mutation that cause increased activity of those sodium channels, they absorb sodium. So their renin-angiotensin level and aldosterone are suppressed Okay, and that is the key difference between them and the primary aldosterone is in patient. So looking at the options, they say which one is not associated with Liddle syndrome. So hypokalemia, of course, is there. Hyponatremia, false, because they are retaining sodium, so that would be the false one. Metabolic alkalosis could be a presentation. Suppressed plasma renin activity, of course, because of the sodium retention that is happening, and low plasma aldosterone level, they are features. So the odd one there is the hyponatremia, is hypernatremia instead. All right, any comments? Moving on to the last one. Yeah. In which of the following categories is salt-sensitive blood pressure change? In which of the following categories is salt-sensitive blood pressure changes least likely? Okay, so it's basically about salt-sensitive hypertension. So the black race, aged people, okay, individual with renal compromise, individual with dysglycemia, they are all prone. But the odd one here is the youth. You don't, it is salt-sensitive blood pressure changes is least likely in young people. But black people, aged people, people with renal compromise, and these glycemic patients, they tend to have, they tend to, in those populations, salt-sensitive hypertension tend to be more prevalent as compared to young people. Okay, so for this one, the option is C. Any comments? I think that should be my last question. So over to you, Chief. Okay. Hello. Hey, is everybody asleep?
We're awake.
Who is next in line?
Dr. Adeyanju. Hey. Dr. Adeyanju.
Hello, good evening.
Good evening, sir.
I've not even, I didn't even know when they passed my thought. I've not yet taken my own part.
Okay, please, what's the page number?
I'm supposed to take from section E, number 28.
Please, do you know the page?
Okay, page 49.
Okay. Okay, this page 49. Which number?
From number 28.
Okay. Okay.
Okay, can I go on? Can I go on?
Yes, so it's like it's only me and you and Dr. Conte that is awake. Please, can people speak up? Can we go on, or we should stop
Please
for the
go
night?
ahead. Go ahead.
Okay.
We are listening.
And you're
Okay.
allowing only us to talk.
No.
Thank
Please
you.
go ahead.
Okay.
Okay. So the number 28 says cardiac syncope is
At least you should. Sorry, please. If people are getting tired after 11, then rather than continuing beyond 11 and just to meet time, why don't we set the time and still finish by 11? So that some persons can catch some rest. I'm just suggesting to the group and to Ade and you, and it's okay. Just a suggestion. Go ahead, Sir Charles.
okay, sir. So, it says cardiac syncope associated with dyspnea and posture-dependent murmur is most likely as a result of A. Aortic stenosis, B. Cardiac myxoma, C. Coronary spasm, D. Pacemaker malfunction, and E. Ventricular tachycardia. Okay, I think the key point in this question is the posture dependent murmur, because virtually all of the options can give syncope, okay, and can also give shortness of breath, okay, but only cardiac myxoma can give a murmur that changes with posture. Okay, actually, this is one of the key things that differentiates a myxoma, especially a left atrial myxoma from mitral stenosis. Okay, because all of them, they can all give the same thing, but it's only a myxoma that will give you a murmur that changes in intensity as the posture of or with alteration in position. Okay, and just one thing for us to remember about a myxoma is that it usually presents with three core um, cardinal features. One is syncope, two, the tumor may embolize, and three, constitutional features like fever, weight loss, and other constitutional symptoms. Okay, so the correct answer is B. I don't know if I can go ahead. Okay, so question 29. They said that number 29 says that syncope that occurs in the course of nasogastric tube passage is likely due to syncope that occurs in the course of nasogastric tube passage is likely due to A. Vasovagal syncope, B. Situational syncope, C. Bradycardia or vasodepressor reaction, D. Hypotension of the orthostatic variety, and E. Neurally mediated syncope. Now, for this question, uh, I don't know, because I'll actually need help, because from the major types of syncope, we know that there are three major types of syncope. Okay, let me just go through it. Three major types or three major causes of syncope. The first one is the neurally mediated syncope. Second one is due to orthostatic hypotension. And the third one is the cardiac syncope. Neurally mediated syncope includes vasovagal syncope, okay, due to maybe intense and prolonged fear, anxiety, intense emotion, and all that. Then syncope due to situational reflexes, which includes things like cough, cough syncope, okay, urogenital syncope, like post-maturation syncope, gastrointestinal syncope, which include swallow syncope, syncope due to instrumentation in the GI tract, rectal examination, defecation syncope, okay, carotid sinus syncope, ocular syncope. I'll just post this on our, because there is a table in Harrison that tries to give, that just lists all these causes of syncope. Syncope due to orthostatic hypotension, cardiac syncope that is due to different types of cardiac arrhythmias like SNO dysfunction, ventricular tachycardias, and so on and so forth. So to me, this syncope that occurs when an NG tube is being passed is likely, because when you say vasovagal syncope, it can be the answer. Situational syncope can be the answer. Okay, all these neurally mediated syncopes as a result of bradycardia and vasodepressor reaction. Okay, so it also can be the answer. The only one that may not be the answer is D. That's syncope due to hypotension, orthostatic hypotension. Okay, but in the answer, Prof said that the answer is C, bradycardia or vasodepressor reaction. Okay, so sincerely, I do not know why the answer is C, because A, B, C, and D can possibly be the answer. If I were to choose based on what I went through, I would have chosen B, situational syncope, okay, because the situation is the NG tube, okay, which is like a sort of gastrointestinal syncope because of gastrointestinal tract instrumentation. To me, I would have chosen B on my own, okay, but Prof chose C, so I don't know. I'll leave it. I'll leave it for the house to decide. Okay, I don't know whether somebody has any comments on this particular question.
Please, I want to read something. I just browsed it as well. They said there's
Okay.
something called nasocardiac reflex. Nasocardiac reflex is a vagally mediated reflex induced by stimulation of the nasal mucosa, which lead to severe bradycardia and even a dramatic cardiac arrest, asystole.
Okay.
So
Okay.
can that
Yes.
explain why he picked C?
What the point I'm trying to make is that all of them, even this one you read now, cardiac reflex, all of them will also lead to bradycardia, because that's how neurally mediated syncopes work. They will all cause bradycardia and this vasodepressor reaction. Okay, because what happens in neurally mediated syncope is that there's a transient change in autonomic activity. They have this parasympathetic they have this parasympathetic discharge and with sympathetic inhibition. Okay, these autonomic changes, okay, will cause bradycardia and vasodilation. Okay, and reduce the sympathetic usually cause vasoconstriction and reduce the vasoconstrictor tone. This is what is called the vasodipressor response. All of them will cause it if you read how neurally mediated syncopes work. Okay, and this autonomic activity will now cause hypotension that will reduce cerebral perfusion and now eventually lead to that will transiently reduce cerebral perfusion and now lead to syncope. Okay, so all of them actually, that's what I found out, will actually cause C, as in all neurally mediated syncopes will actually cause bradycardia, and so I don't know. That's why I was actually a little confused with this particular answer, but it's okay. Hello.
Yes. Okay. Can we move?
So let's move on. Let's move ahead. Let's move ahead. Question 30. A 56-year-old man presents with recurrent fainting attacks. Further history, physical examination, and a 12-lead resting ECG are helpful in unraveling the cause. Which of the following will be the appropriate next investigation? Okay, so the options are echo, stress ECG, ventricular function studies, prolonged ECG monitoring like loop event recorders, and electrophysiology studies. Okay, so the answer is prolonged ECG monitoring like loop event recorder. So this patient that has recurrent syncope and examination, ECG are not helpful. So it's important for us to look for arrhythmias as source of his syncope, okay? Because like I was talking about in the former question, when it comes to cardiac syncope, there are various arrhythmias. Let me just list them. Maybe I'll post this on the WhatsApp. There are various arrhythmias that can cause syncope, including whether it's SA node dysfunction, AV node dysfunction, SVTs or SVTs, supraventricular tachycardias, ventricular tachycardias, channelopathies, even so. It's important for us to do Holter actually to check if he has any of these arrhythmias coming in intermittently. So that's the answer. D, Holter is the answer. Okay, can I move on? So 31, a patient with syncope and has a negative history. A patient with syncope has a negative history, physical examination and ECG. If no heart disease, and the episodes are repeated, which of the following next step is appropriate? Okay. So in this kind of patient, the correct answer is actually a carotid sinus massage. A carotid sinus massage. That will be the correct answer here. Okay, that will be the correct answer here. Is one of the things you may perform. That's a carotid sinus massage, and it may be diagnostic in elderly patients. Okay, a positive response will include bradycardia and asystole. Okay, so that's how you know if the massage is positive. Okay, so that is the answer, option D. Option D. Option D. Okay, I don't know whether we can continue. It's almost 11.
Yes, please continue, sir.
Okay. All right. So we'll go to section F. Number 1 says an average nocturnal systolic blood pressure decrease of less than 10% of daytime mean refers to A, extreme dipping, B, modest surge, C, non-dipping, D, normal dipping, E, reverse dipping. Okay, so the answer here is non-dipping. Normally, like we know, normally blood pressure dips during sleep. The normal dip is usually about 10 to 20% during sleep. Okay, and usually 30% of individuals are called non-dippers. 30% of individuals are called non-dippers. Okay, and non-dipping is defined as a less than 10% dip during sleep. That's what we define non-dipping as. So normally BP should normally dip about 10 to 20%. So if this dip is not up to 10%, we say the individual is a non-dipper. Okay. If the blood pressure actually rises during sleep, we say the individual is a reverse dipper. Okay. And it's important for us to know that nocturnal hypertension, that's reverse dipping, and non-dipping patterns are associated with increased cardiovascular morbidity and mortality. Okay, so morning surge is defined as increase in blood pressure. Okay, after over the transition from being, there's a specific value, but I can't remember it now. Over the when a person transitions from being asleep to being awake, that rise in BP is called morning surge. Okay, so but here the answer is non-dipping. The answer is non-dipping. Number one, C. Section F, number one, C. Okay, so number two, can I proceed? Okay. Number two, orthostatic hypotension is defined as, the correct answer is defined as A, systolic blood pressure more than or equal to 20 millimeter of mercury, and or diastolic blood pressure more than or equal to 10 millimeter of mercury reduction within 1 minute of standing. B, systolic blood pressure more than or equal to 15 millimeter of mercury, and or diastolic blood pressure more than or equal to 5 millimeter of mercury reduction within 2 minutes of standing. C, systolic blood pressure of more than or equal to 20 millimeter of mercury, and or diastolic blood pressure of more than or equal to 10 millimeter of mercury reduction within 3 minutes of standing. D, systolic blood pressure of more than or equal to 10 millimeter of mercury, and or diastolic blood pressure of more than or equal to 5 millimeter of mercury reduction within 5 minutes of standing. And E, systolic blood pressure more than or equal to 20 millimeter of mercury, and or diastolic blood pressure more than or equal to 10 millimeter of mercury reduction within 5 minutes of standing. The correct definition here of orthostatic hypotension is option C, which is a systolic blood pressure difference of a systolic blood pressure reduction of more than or equal to 20 and diastolic of more than or equal to 10 within 3 minutes. 3 minutes. So 20 and 10 and 3 within 3 minutes of standing. That's the correct definition for orthostatic hypotension. So number 2 is C. Okay. Number 2 is C. So of number 3 is which of the following does not increase blood pressure morning surge? Which of the following does not increase blood pressure morning surge? A, alcoholic binge. B, cigarette smoking. Alcoholic binge. B, cigarette smoking. C, first day of the working week. D, normal glycemia. And E, old age. Okay, so the correct answer here is normal glycemia. All the above there are different factors that affect morning surge from alcohol, from cigarette smoke. In fact, there's as I was looking for the answer, I found a what do you call it? A document that listed a lot of factors that predispose to morning surge. So I'll put it on our WhatsApp. Okay, but for option D, what makes it false is that they said normal glycemia. So either hyper or hypoglycemia, any glucose abnormality will actually affect morning surge. Okay, but other things that affect morning surge, other risk factors include age, hypertension. I've talked about glucose abnormality, metabolic syndrome. Okay, then some behaviors like alcohol, smoking, stress. That's why the first day of the working week, Monday, is usually associated with stress. Okay, then physical activity in the morning, all those things will affect morning. So then poor sleep, some sleep conditions like poor sleep and nocturnal hypoxia, maybe people who have obstructive sleep apnea, it will affect morning surge. Then some seasons like winter, they even wrote Monday, or all those will also affect morning surge. So the correct answer is D. Correct answer is D. I'll put what I just said now, put it on the WhatsApp group. Then number 4, it says which of the following is out of place as a clinical predictor of salt-sensitive hypertension? Which of the following is out of place as a clinical predictor of salt-sensitive hypertension? A. Android obesity. B. Elevated blood pressure. C. Hyperinsulinemia. D. Postmenopausal age. E. Relative youth. So all of the following, sorry, all of them will affect salt-sensitive hypertension. Apart from youth, there's no association between youth and salt-sensitive hypertension. So option E is the correct answer. Option E is the correct answer. Okay. So number 5, which of these situations is more likely to produce white coat as opposed to max hypertension? A. After a large meal in the elderly. B. Mental stress at work. C. Alcoholic binging. D. Peak and trough drug effect. E. Encounter with a masked hospital staff. Of course, we know that white coat is when blood pressure appears to be within normal, except when the patient visits the health facility. Okay, so of course, what will be if the person sees a masked individual? Okay, that's why it's called white coat. A masked hospital staff. Okay, to actually trigger white coat hypertension. So the answer is E. This one is actually straightforward. Option number 6. Plasma renin and aldosterone levels could be raised in some hypertension and hypokalemia states. Which of the following fits that bill? A. Renin secreting tumor. B. Liddle syndrome. C. Cushing syndrome. D. 11 beta hydroxylase deficiency. And E. 17 alpha hydroxylase deficiency. Of course, all of them will cause hypertension and hypokalemia, Liddle, Cushing's, okay? But for option A, a renin secreting tumor will secrete renin, okay, which will raise renin levels, raise plasma renin, and also raise aldosterone, to raise renin and aldosterone levels, okay, and this will cause secondary hyperaldosteronism, okay, which will have hypertension, hypokalemia, okay, they will also have hypertension and hypokalemia, but unlike the others where renin and aldosterone will be normal, here, because of the renin secreting tumor, renin and aldosterone will be very elevated. Okay, so the answer to number 6 is A. Answer to number 6 is A. So this brings me to the end of my own section. I don't know whether there are comments from the house. Thank you.
Thank you very much, Dr. Corey. Please, are there further comments or questions? Additional comments, please. Okay. Please, do we have any other person that's ready with his part? Okay. Okay, please, who other person is ready with his part? Oh, wow.